Good morning, everyone. I'm Dr. Priyanka. Today's lecture topic is provisional restorations. Coming to the learning outcomes, we have three learning outcomes. So, first is the requirements of a successful interim restoration, right? So, interim restoration is another name for a provisional restoration, and to describe the current available materials for fabrication of interim restorations, materials, properties, and its advantages, disadvantages, indications. Okay, coming to the definition. So, according to the GPT-8, provisional restoration is a fixed or removable prosthesis designed to enhance aesthetics, stabilization, and function for a limited period of time, after which it is to be replaced by definitive prosthesis. Okay, so synonyms are temporization, interim prosthesis, and provisional prosthesis. Coming to the importance, so provisional restoration is given for a period of time until a permanent arrangement can be made, okay, to protect the prepared tooth and kept patient comfortable, okay. By successful treatment with provisional restoration, dentists can get the patient's confidence, which is an influencing factor for the success of the final restoration. Okay, come to the requirements again in a Venn diagram according to Rosenstiel. So we divide the requirements always in biologic, mechanical, and aesthetic principles. So in biologic, the things remain the same, guys. Okay, so to protect the pulp, maintain the periodontal health, to provide occlusal compatibility, maintain tooth position, protect against fracture. Okay, in mechanical, you have resisting functional loads, resisting removal forces, maintaining interabutment alignment. Okay, for aesthetics, you have easily contourable. It should be color compatibility should be there, translucency and color compatibility should be there. Okay, coming to biologic requirements, pulp protection is very important, guys. Okay, so during, we have talked about it earlier many times, during tooth preparation the dentinal tubules are exposed, thus the provisional restoration should protect the prepared tooth from oral environment, thereby preventing sensitivity and irritation to pulp. Okay, so you should be only preparing where required, not near the pulp. Okay, so periodontal health, it should have a good marginal fit, proper contour, smooth surfaces to prevent accumulation of plaque, facilitate easy plaque removal, and maintain periodontal health. Okay, so this is an example, guys. Okay, this is the crown prepared, and this is the provisional restoration. Okay, here has been chipped off, so rough margins around interim restoration will jeopardize the subsequent procedure. It would cause swelling in the gingiva, right? It would cause sensitivity in the tooth if it's a vital tooth, right? So we have to contour it properly and we should have a smooth surface. Okay, plaque will accumulate, there will be swelling in the gums. All right, positional stability, so it should provide a comfortable, stable, and functional occlusal relationship by maintaining interarch and intraarch stability, thereby preventing tooth migration or supraeruption. Okay, so if an interim restoration does not ensure positional stability, tooth movement will occur, guys. Okay, so everything has to be, if you feel it's the contact is too tight here, right, and the margin is short, remove the premature contact points and fit in. It will fit in. Okay, all right. Prevention of fracture. So it should protect the prepared tooth surface from fracture, which is commonly seen in partial coverage crowns, in which margin of preparation is close to the occlusal surface of the tooth and should be damaged during chewing. All right. A missing proximal contact allows tooth migration. Okay, the resulting tooth proximity may necessitate surgical or orthodontic correction. So do you see there, there's no place and it's inclined on the wrong axis. Okay, should be always on the long axis of the tooth. All right, okay. Coming to fractured or chipped off restoration, so the interim restoration must protect the tooth. Fracture of the tooth after the impression phase delays the treatment and jeopardizes the restorability. Okay, okay. Coming to the mechanical requirement, Functional requirement, it should possess good compressive and fractural strength. The strength of the material used for fabricating provisional restoration is always much lower than that of definitive restorative material. But still, it should be able to withstand normal forces, okay? The greatest stresses in provisional restoration occurs during chewing, okay? So loss of retention is another point. It should have close adaptation to the prepared tooth surface to prevent any displacement or re-cementation, okay? Which increases the patient's visit, okay? So look at the contours, guys, okay? So you don't need to over contour any crowns. Okay, any of the over contouring will lead to accumulation of plaque and create swelling in the gingiva, and there will be caries. Okay, if in case there's any vital teeth involved. Okay, all right. And over contouring, um, not all the time will improve the strength. Okay, removal of or reuse. Okay, so provisional restoration may be removed and re-cemented often. Okay, they can, if they are well fabricated with adequate thickness and cemented with weak cement, it can be removed without breakage. Okay, so it can, okay, you don't really need to, but then it can be. Aesthetic requirements, it should match the shape, size, color, texture of the restored teeth, especially in the anterior region. Okay, color stability is also important if the provisional are to function for a prolonged period. Okay, it also serves as a guide to achieve aesthetics to a final restoration. Okay, so as you can see, this was the previous and this is the post-op. Okay, right? Okay, this is the post-op, guys. All right. Okay, coming to the classification. So according to the method of fabrication, so it's divided into four bases, guys. Okay, so according to method of fabrication, it is free-form, custom-made. According to material use, it is resin, that is free-form, custom-made, polycarbonate, cellulose acetate, acrylic, bis acryl, composite. We are using acrylics here. Okay, right. So coming to, we are using acrylics, yes, guys, okay, and this acryl composites, okay. Metals is also preformed, custom made, aluminum, tin, silver, nickel, chromium, cast metal alloy. We are not using, okay. According to the duration of use, it is short term, long term. According to the technique of fabrication, direct and indirect, okay. Ideal requirements of the provisional materials. So it should be convenient to handle, it should be biocompatible, it should have dimensional stability during solidification, should be easy to contour and polish, it should have proper strength and abrasion resistance. It should have good aesthetics and patient acceptance. It should have ease of adding to or repairing. It should have chemical compatibility with the coating agent. Okay, so material used are resins and metals. So in resin, there's acrylics, so that is polymethyl methacrylate. Okay, poly or methacrylate. Bis acryl composites, chemically activated, light activated, dual activated. All right. And then metals are cast metal alloys. So these are examples of some crowns. Okay. So this is polycarbonate. Okay. And this is cellulose acetate. Um, these are aluminum shells, guys. Okay. And silver, tin silver crowns. Okay. Okay, coming to polymethacrylate advantages. So low cost and good wear resistance is main here. Good aesthetics, high polishability, good color stability. Disadvantage is significant amount of heat given off by exothermic reaction, high degree of shrinkage, strong objectionable odor, short working time, hard to repair, and radiolucent. Okay, coming to bis acryl composites, advantages are less shrinkage than acrylics, um, minimal heat generation, excellent aesthetics. Most products use automix delivery system. We use it here too, guys. Okay, easy to trim, radio opaque. Disadvantage: greater cost than acrylics. Viscosity cannot be altered. Sticky surface layer present after polymerization, more brittle than acrylic. Okay, coming to preform provisional restoration, guys. Okay, depending on the material types, it can be resin based or metal based, cellulose acetate, and polycarbonates, and polymethyl methacrylate, polyar methacrylate, microfill composite urethane dimethacrylate. Okay, so these are resin based, metal based. One of the examples are here. This is tin silver. Okay, aluminum, nickel, chromium, tin silver. Okay, so I will just be covering four of the main important ones. Okay, rest of them you can list down. So resin, right? So polycarbonate crowns, right? They combine microglass fibers with polycarbonate plastic materials. Okay, it is used as a matrix around a prepared teeth. Okay, it possesses high impact strength, abrasion resistance, and good bond with methyl methacrylate. Best aesthetics among all the preformed crowns, available in shape of incisor, canine, premolars, and varying sizes. Okay. Right, coming to cellulose acetate, this is a more transparent looking crown. It is thin, soft, transparent scaffold material. It is available in all tooth shape and different sizes. It does not bond to the relining resin. An approximated size of this crown is selected from a mold guide and filled with auto-polymerizing resin of appropriate shape. Okay, so this is inserted over the lubricated prepared. Okay, coming to the metals, so aluminum, these are generally limited to posteriors for aesthetic reason. Okay, available as simple shells. They provide good adaptation due to softness of material, but it can also promote rapid wear resulting in perforation, right? Especially on the occlusal surface. They can be relined with resin to obtain better fit and rigidity and then luted to prepare tooth. Nickel chromium indicated for use in children with damaged primary teeth. They need not to reline with resin. They are trimmed, contoured, adapted to the tooth, then cemented on the tooth surface. Okay, or tooth. Okay. Coming to techniques of fabrication. So now we have three techniques: direct procedure, indirect direct. Okay. So direct basically is these are constructed with the matrix lined with provisional material that is placed directly on the prepared teeth or directly in the patient's mouth. Okay. Indirect is all on the cast. Okay. So they are constructed by placing the filled matrix over a model of prepared tooth. Thus, the provisional is constructed outside the patient's mouth. Only it is cemented inside. Okay. Corrected and cemented or relined and cemented. Indirect-direct, these are made by forming a temporary in an indirect manner and then relined this directly in the patient's mouth. This method is useful when constructing temporary bridges and when you're sending a bulk of work to the lab. Okay, so that is what we're doing here. Okay. Coming to the direct technique. So in direct technique, patients' prepared teeth and the gingival tissue directly come in contact, provide this tissue surface form, eliminating all the intermediate lab steps. Okay, so this is convenient when assistant training or any officer or lab facility are inadequate for efficiently producing an indirect restoration. Okay, so however, the direct technique has significant disadvantages like potential tissue trauma from the polymerizing resin, and inherently poor marginal fit. Okay, therefore, the routine use of directly from internal restoration is not recommended when indirect technique are feasible, guys. Okay, so this is a case report. So preoperative photo, right? We're replacing the lateral. What we do is we put a pontic from our RPD. Then we mix the putty and we take an index, okay? So either you have a full arch, either you can take a small index, okay? After this, the putty index with the RPD is trimmed, right? It comes out together with it, okay? Applying application of separating media on the prepared teeth, all right. So a resin mixed and poured in the index, okay? So it is poured and then again the index is reseated in the patient's mouth, allowed to set with RPD in the index, and then the provisional strip, and then it is cemented in the patient's mouth, okay? Okay. Indirect technique. This technique involves fabrication of the interim restoration outside the mouth. Fabrication of the provisional restoration uses restoration using the indirect technique, eliminating the problems associated with the direct technique, okay? And also has advantages that it can be partially delegated to auxiliary personnel, right? So okay, the technique has several advantages over the direct procedure. Okay, there is no contact of free monomer with the prepared teeth or gingiva, which might cause tissue damage. Okay, and an allergic reaction or sensitization. Okay, so the technique avoids subjecting prepared tooth to heat evolved from the polymerizing resin. Indirect technique produces restoration, which is with a superior marginal fit, and as an auxiliary it is um, involved in fabricating the restoration in the lab, okay? So it frees the patient and the dentist's time, all right? So when compared to direct technique, it has fewer demerits. Principal disadvantage of this technique includes increased chair side time, and increased number of intermediate steps. So it's a tedious procedure. Okay. In addition, the technique involves use and possible damage of the diagnostic cast. Okay. Okay, so diagnostic cast with the missing mandibular incisors, you place the pontic from the RPD, all right? You have vacuum form sheet adaptation, you can do this, okay guys? Or you can make a putty index, anything is okay. You have a prepared tooth, you can prepare it on the cast. Okay, it's just showing how it's going to be prepared in the patient's mouth. So you have done a tooth preparation on the cast, template has been placed, template, putty index, or the vacuum form sheet. The provisional has been loaded inside, it is pressed and it has been removed, and this is what you can see. Now it is trimmed properly and again fitted in the mouth. Okay, so now when the patient comes, it's really easy, and now you have you can just make a temporary like that, okay, and you can just cement it. Okay, all right. And check the fit. Okay, now coming to indirect direct method. So we are doing half work there indirectly, also doing the other half directly. Okay, like what we are doing here. So the technique produces a custom made preform external surface form of the restoration, but the internal tissue surface form is formed by the under prepared diagnostic cast. That is indirect direct procedure, has several advantages. Okay, so with the combination, the indirect direct procedure technique or chair time can be reduced. Okay guys, sorry, so this technique produces a yeah, okay, so with the combination of indirect direct technique, chair time can be reduced since the provisional shell is fabricated before the patient's appointment. Okay, so enhanced control over restoration contours minimizes the time required for chair side adjustments, and additional, a smaller amount of acrylic resin will polymerize in contact with the prepared abutment, resulting in decreased heat generation. Okay, chemical exposure polymerization shrinkage compared to the direct technique. Okay, another advantage is that contact between resin monomer and soft tissues is reduced and less chances of allergic reactions are there. Okay, so disadvantage of this procedure is the potential need of the laboratory phase before tooth preparation and the adjustments that are frequently needed to seat the shell completely under the tooth. Okay, so it starts from here. So we have an edentulous cast. Okay, and you have added wax to correct it. All right. Okay, so now we make a putty index of the same, guys. Okay, we can do a minimal tooth prep on the model. Okay, preparation complete on the model, and then when you have the putty index, you can pour the temporary. You can let it rest by the rubber band. Okay, and then you see it on the cast, and then now in the patient's mouth, you can prepare the abutments and just reline any acrylic resin if you need to add or if you need to trim it out, stabilize in the patient's mouth and cement it. Okay, so rather than preparing it on the model, you can just prepare it on the teeth surface. That's what we do here. Okay, so that is one alteration of the technique which we are doing. Okay, all right. So coming to the removal, re-cementation and repair. So these are just for your information, right, guys? Okay. So familiar instruments, right? So this is an automatic crown remover. You call it automatic crown remover, okay? Because you just have to place the tip and you have to exert pressure and it clicks out. This is known as a hemostatic forceps, right? Sometimes you use this also to remove the crown. Okay, so in this, what happens? You can avoid the fracture of the tooth anyway. We're not fracturing any tooth, anyways. Okay, so again, you break the seal, you give a slight buccolingual rocking motion required to break the cement seal, and you can move it and remove it. Okay, so these are two forms which crowns can be removed. Okay, so coming to the cementation procedure, this is the one we are using in our department. Okay, we are using zinc oxide eugenol. Okay, so cementation, ideal properties of the cement is the ability to seal against leakage of the oral fluids. Strength consists of intentional removal, low solubility, chemical compatibility with the provisional polymers, ease of eliminating excess, okay, adequate working time and short setting time. Alright, cements uses zinc oxide eugenol, reinforced zinc oxide eugenol, non-eugenol cements. Okay, we do not use the permanent cement as they have high strength. Okay, makes intentional removal very difficult, and then you can have tooth surfaces chipping off. Okay, so this is the temporary cement we use. Coming to limitations, so limitation as such of a provisional restoration is that it lacks inherent strength, it has poor marginal adaptation, color is a problem, it wears out, it has odor, bonding is not so adequate, it has poor tissue response if you leave it for a long time, guys. Okay, it difficult and incomplete cement removal may create inflammation in the gums. All right. Okay, the bibliography is again the standard textbooks Rosenstiel and Schillenberg of FPD. All right, thank you so much for patient listening, guys. For any problems or questions, you can come and see me.